Hello, and welcome to Med News Week, the rising leader in global medical education. You're watching Medical Spotlight, where we highlight the inspiring stories and pioneering research innovation of medicine's rising stars and global leaders.
Hello, and welcome to Medical Spotlight. I am Helena Coloma.
And I'm Gayatri Menon.
Today, we have with us Dr. Eric Singhi from the University of Texas MD Anderson Cancer Center. Dr. Singhi is an assistant professor and thoracic head and neck medical oncologist at the MD Anderson Cancer Center. He graduated from medical school at the Medical University of South Carolina, completed his internal medicine residency at Vanderbilt University, and completed his hematology and medical oncology fellowship training at the MD Anderson Cancer Center in 2022, while serving as Chief Fellow of UT Resident Education and Chief MD Anderson Education Fellow.
Dr. Singhi has an interest in medical and patient education, patient-reported outcomes, and personalized care. Dr. Singhi has published dozens of peer-reviewed articles in this area and has received numerous awards, including the 2022 Young Investigator Award from the EGFR, a Resistors Research Summit, the Patient Education Ambassador from the Global Resource for Advancing Cancer Education, the Junior Faculty Travel Award from the Hawaii Global Summit on Thoracic Malignancies, and the MD Anderson Cancer Center Awesome Job Award, among many others. He is an active member of many national and international professional societies and committees, including the American Society of Clinical Oncology, SWOG Cancer Research Network, and the International Society for the Study of Lung Cancer. He is also a globally invited speaker and a passionate mentor, serving as a leader and educator.
Now, Dr. Singhi, behind every person in a white coat is a story and a mission for why they pursued this journey and career. Can you tell us about yours?
Absolutely. And thank you so much for the kind introduction. I really appreciate it. Yeah, I think that's a great question. I think it's really important to humanize the physicians, the providers that patients meet on a day-to-day basis. And I'm a big fan of that and sharing stories. So, I was really inspired to get into medicine because of my maternal grandfather. He was actually recruited from India almost 50 years ago to be a family medicine physician here in the United States. Brought my mom, my uncle at the time, who were teenagers, to a brand new culture for new opportunities. And he was really incredibly passionate about applying his skill set in medicine and translating that into excellent patient care for his patients, children, adults, the whole gamut of patients, honestly. And so I spent a lot of time with him, growing up in Ohio. He was in a very small town in Ohio. And I would listen to his stories about interacting with patients. And he took such pride in really, owning their patient care and getting to meet their families and their loved ones and their caregivers. And so really seeing someone that I respected so much on a personal level have so much pride in his profession was something that really stuck with me just growing up. And I really cherished that. And it was always in the back of my mind. And so unfortunately, my grandfather passed away about a month before I graduated from fellowship. But he got to see the milestones of me getting my white coat, me, starting residency, starting fellowship. And, I think of him very fondly, and he's really my true inspiration for getting into medicine.
That's so wonderful. Thank you for sharing. And you'd mentioned that from seeing your grandfather and how he interacted with patients. And I see that now you're an advocate yourself for medical and patient education, and especially in their personalized care. And I see you have a great presence on social media as well, too. So what inspired you to raise awareness on this particular platform for it?
Yeah, I think that's a great question. So, I think I definitely learned about the provider side from my maternal grandfather, but when I was younger, before I was even in my teens, my family was impacted with a diagnosis of cancer as well. So I was still pretty new to really understanding a lot about what was going on in the world, let alone just cancer. And so when I first heard that word, it was definitely very daunting. It was, a really new experience that I wasn't used to. It was a very uncomfortable experience. And what I learned from having a diagnosis of cancer in my family was, the impact that it has not only on the person that has cancer, but on their family members, on their caregivers, on their loved ones, the emotional toll, the physical toll. understanding the diagnosis. Patients and families are thrown immediately into a whole new world of language they don't understand, new tests, new labs, new scans, new treatments. How do they process that? How do they understand it? And so, I kind of put both hats on of having been myself, a family member, someone that's gone through a diagnosis like that, and then also being the provider and caring for patients and their loved ones. And, I've been very passionate about simultaneously kind of syncing both of those aspects of care together so we can support our patients and support their families. Your question about being an advocate and getting more involved with patient advocacy is a really good one, because I wasn't very familiar with that whole aspect of care until I joined and was accepted to a program called Cancer Grace, which is the global resource for advancing cancer education. It's a nonprofit organization that's incredible. It's dedicated to specifically enhancing patient education that's out there for patients with a diagnosis of cancer and their loved ones and their family members. And so I applied to be a patient education ambassador through that program in 2022 and was accepted. And that was really an excellent opportunity to get involved with key leaders in the digital field in medical oncology, get involved with patient advocates and learn about their role, their very active and much appreciated role in advocating for research efforts, advocating for patient education, and advocating for enhancing the patient experience as they get their cancer treatments. So that's sort of how I first navigated and learned about that whole field and how I might be able to get involved.
That's so great. That's awesome. From your time in that program as an ambassador, you mentioned there were role models in a way that you could look up to. And so that brings me into my next question, actually, about mentorship in medicine and helping one's journey. For you, given your experience, what makes a good mentor for you? And who was that for you in this particular program, since I know you mentioned there were several speakers that were part of it?
Yeah, I think mentors and sponsors are two very different buckets. You may have an individual who can mentor you and sponsor you, but it's really important to identify both mentors and sponsors to really advocate for you throughout your entire sort of career path. And so specifically for this program, the Cancer Grace program, one of my very close mentors and sponsors is actually Dr. Jack West, who is a very key leader who advocates very fiercely for his patients and advocates for excellent care, specifically for patients with lung cancer. And so this was actually his nonprofit organization, Cancer Grace. And so I got to connect with him, really think critically about the treatment options that we have for patients, not only what it does for endpoints like, of course, progression-free survival, overall survival, response rates, but really what it does to the patient and the patient experience. And so I would say he's been a very key mentor, sponsor for me. Of course, I got to really interact with a lot of patient advocates as well as a result of this project. And so one of my close friends now, and also I consider a mentor, is Jill Feldman, who is an excellent, amazing patient advocate and is one of the co-founders for the EGFR resistors group. And she has really opened my eyes to how we can connect and better understand the patient experience. I mean, who is a better person to ask than the person that's actually going through treatment, actually on the treatments that we are prescribing? And so I would say I have mentors and sponsors from patient advocates to senior leaders in oncology. Really have had excellent mentors and sponsors throughout all phases of my career. As early as my internship and residency at Vanderbilt University, I had an amazing group of mentors and sponsors there. Leora Horn, Christine Lovely, both of them took a lot of time to mentor me and to offer me incredible opportunities to advocate and move forward in my career. So I'm grateful for that.
Yeah, so thank you also too for defining how important mentorship is versus sponsorship, especially in like helping you in your journey to help you where you are now. And then given that, how does then this strong passion for mentorship that you have, how does it manifest in your present role, in your current roles? Are you currently applying any of the mentorship skills that you learned back then to guide and support any of the future junior colleagues that you currently work with?
Absolutely, 100%. So I think one of the silver linings that we've come to appreciate from the COVID-19 pandemic even was just that it's feasible to, obtain remote mentoring, obtain remote sponsorship. I learned that through the Cancer Grace program with Dr. Jack West, Jill Feldman, like I mentioned before. And so one of the things I'm a big believer on is, the opportunities for remote mentoring. And so I have several mentees now who are not physically at my institution, but I'm actively connecting with them, actively working on research projects, actively coming up and brainstorming ideas, open to talking to them, not only about research projects, but also about, job opportunities, thinking through other opportunities, both, outside of work as well in their personal lives. So I'm very open to remote mentoring, very open to remote sponsorship. I also have a really strong passion for medical education. And so I was a chief fellow in 2 different roles during my fellowship here at the University of Texas MD Anderson. And I wanted to sustain sort of that involvement with medical education. And so I am now one of the co-directors for a Thoracic Medical Oncology Rotation for our medical oncology hematology fellows here at MD Anderson. And so I am actively working with trainees who are going through their medical oncology fellowship. Some of them also have an interest in thoracic medical oncology, and we've worked on projects together. We've sat down and gone over very unique and difficult patient cases. We've talked about job opportunities. We've talked about personal life. So, I'm very grateful to be able to pay it forward, essentially.
That's great. That's actually very powerful to be able to pay forward what you learn to the next generation and help them. That's truly very inspiring. And when it comes to one's journey, all humans encounter setbacks in their life, but they can make you or they can break you. Would you mind reflecting on a challenging time that you had in your life or in your journey thus far, and how you suggest, especially to our trainees in the audience, how they should approach these kind of speed bumps?
Yeah, I think that's a really thought-provoking question as well, because we all now are so focused on this digital age, especially platforms like Twitter or X, Instagram, Facebook, where a lot of us post about all the accomplishments that we have, right? All the accomplishments and successes and success stories. Very rarely do you see that raw side of rejections, of times where there were failures. How do you turn those experiences into a more positive experience, and how do you turn them into learning experiences? As an example, I myself applied for an ASCO YIA, and I did not get the ASCO YIA. That was my first grant opportunity writing it. Spent a lot of time thinking about it. Admittedly, saw that as a challenge, but ultimately, I got to connect with Jill Feldman even further as my patient advocate. We've come up with several other projects. I was able to turn a project into an oral presentation at an international conference. And so, sometimes it's not just about the destination, it's about the journey. It's about the people that you meet, the connections that you make, the skill set that you learn by just going through different opportunities. And so I think we need to all be more open about not only the success stories that we have, but some of the failures and the challenges that we have and what we learn from them. And so those are just some personal examples. I think taking a step back to a collective experience that we all shared together, sort of venturing into the unknown, if you will, is the COVID-19 pandemic, right? It was such an abrupt transition. I was in the middle, actually pretty early beginning phase of my training and fellowship. And so very abruptly, we had to transition to social distancing precautions. We really needed to prioritize not only our patients' health, but also provider health, what that meant in terms of safety for everyone, right? And so I was actually one of the chief fellows for our education program at that time. And as an example of how I turned a sort of unknown experience into a positive was I had just come back from vacation abroad. And the day before I was coming back, our institution made a guideline and said, you're going to have to quarantine for 2 weeks, because of all the new changes that were happening, and to isolate and reduce risk transmission. So I was on a pretty critical rotation at that time and was very worried about what I was going to do, if I was going to have to extend my time in training, things like that. What would it look like if I didn't have PTO, for example, as a trainee? And I remember my program director at the time called me and she was like, don't worry, like we can turn this into a positive experience, despite all of us, really panicking at that time. And so what we did was I basically led a survey trying to better assess the fellows' perception and understanding of how we might transition and continue to derive a good medical education experience during the pandemic, because a lot of us had to transition from in-person didactics to a full virtual curriculum. How do you do that? What do fellows think about it? And so I was able to actually publish that information. It's been cited several times as sort of a launching point for other people that are interested in studying medical education. What did the COVID pandemic do to medical education? And so that's another example where we got thrown into the unknown, and you can turn it into something positive, right? You spend some time thinking about what can you glean, what can you learn from that experience.
Thank you so much, Dr. Singhi, for sharing your background and your story, speaking about all the initiatives that you started, just all by yourself, just taking experiences that you had. And we would love to hear more about your research as well, too.
Yeah, happy to. So as you mentioned, have kind of alluded to, my key interest areas are really focusing on patient education, patient-reported outcomes, and thinking about how to better personalize sort of the cancer experience that patients are going through. And so one of the projects I worked on, I think I've talked a little bit about already, was through the Cancer Grace program. Essentially, that's a longitudinal experience where you get to connect with a bunch of key leaders in the field of oncology. You connect with patient advocates. You connect with a wide array of people that have a common interest of enhancing patient education. And we're asked as education ambassadors for that program to come up with a sort of final project. And so I was racking my brain at that time trying to think of a project that would be feasible to do in sort of a short, abbreviated time frame, but still meaningful, like have a really strong impact for patients and in the field of patient education. And so ultimately what I did for that program was I thought about, one of the times in the longitudinal experience that is, care for patients with cancer, what is one of the most anxiety-provoking times that patients, really encounter? Same with their loved ones, their caregivers. And so what we did was we created a patient-friendly guide to navigating the first medical oncology visit experience. Very simple, and just distilling it down into a one-page front side, back side guide. And I got to connect with several patient advocates. I got to connect with a medical oncologist who helped me translate it into Spanish, because I'm a big believer in making sure we meet our patients where they are. And one of the ways to do that is through, speaking to them in the language they can understand. So we developed this education sheet, got a lot of excellent feedback. That's now an open, publicly shared guide that's available to anyone that wants to use it. I actually have heard a lot of great feedback from a lot of our trainees and fellows using it at our safety net hospital that's connected here with MD Anderson, through Harris Health, our LBJ hospital. I'm a big believer that the people that are going through the treatments really should understand their diagnosis, should understand their treatment plan, should understand potential side effects. And so that was an easy, kind of nice guide and a focus of research that I worked on through that program. Kind of taking that a little bit further and thinking about some publications and how that kind of sprung off of that. I did publish a patient-friendly sort of patient page in JAMA Oncology that basically used patient-friendly language to better explain the experience of a multidisciplinary conference and what that means. And so one of my big key interests is really providing personalized care to my patients, specific not only to their tumor and disease biology and characteristics, but very specific to the patient themselves, patient goals, their social support, meeting them where they are exactly in the social situation that they're coming to me with. And so a question that I got asked several times when I was a trainee at our safety net hospital, and even as an early attending at the university hospital, was, what does a multidisciplinary conference mean? What does a tumor board mean? And so I wanted to think of a way to really explain that quickly to patients and get them to better understand exactly what that experience was. And so I published a paper in JAMA Oncology, kind of distilling that down with a really nice illustration that patients could see and could appreciate in terms of better understanding that process. And so that's just another example of a patient-friendly project that we worked on.
Thank you so much, Dr. Singhi. So that's really amazing. You spoke about your unique background as well as research. And you sound like a lifelong learner, which is truly wonderful. Pivoting a little bit into the more hardcore research you have done, I must say, In 2022, you published a study in clinical lung cancer showing that anti-PD-L1 monotherapy is effective and well tolerated among older adults with advanced non-small cell lung cancer. Can you maybe tell us a little bit more about this study and its broader clinical implications, and how has it affected yours and your colleagues' practice as well?
Sure, yeah, of course. So you're alluding to exactly that publication that we worked on, where we essentially wanted to focus on a group that's often excluded. So how do you include the excluded? And so what I mean by that is focusing specifically on older adults with a diagnosis of advanced stage metastatic non-small cell lung cancer. What we know is that in most of the pharmaceutical clinical trials that led to approval for immunotherapy, older adults were largely underrepresented. And so we don't really fully have a good understanding of the therapeutic outcomes in the specific population with immune checkpoint inhibitors. Age-related factors can definitely influence the immune system. So these are concepts that we really should be thinking about. And so what we did was we utilized our MD Anderson Cancer Center Gemini team's lung cancer database. And this is a database that has disease characteristics, has patient characteristics, and of course, patient outcomes to really retrospectively study patients that we defined as older adults. So we said age 70 or older was our cutoff. They had to have a diagnosis of advanced stage non-small cell lung cancer, and they were treated with anti-PD-1 or PD-L1 monotherapy, and we looked at their clinical outcomes. We, I think, identified about 180 patients right around there that met in the inclusion criteria for retrospective analysis. The median age of the cohort was around 75 years, I believe. And we saw that the patients did derive a very good clinical outcome. I think the median overall survival was quite surprising. It was 20.6 months. And just over 25 to 27% of patients had an objective response to therapy. What I found really interesting and actually led to a spin-off publication that I published just earlier this year was that we saw, as we were going through the database, that there was a cluster of patients who, despite having documented radiographic progression on immune checkpoint inhibition monotherapy, we saw that they continued to receive immunotherapy beyond that documented progression because there was perceived clinical benefit after a discussion with the patient and the provider. And so we identified 33 patients who met that criteria, who continued on immunotherapy despite having that first documented radiographic progression. And we saw that the average time for them to continue on immunotherapy beyond radiographic progression was actually a little over 7 months. So that's a pretty significant amount of time to keep the patient on the same type of therapy, even when they first had that objective documented RECIST criteria radiographic progression. So they were still deriving clinical benefit. Some of these patients did get local consolidative therapy so that, we attacked some of their sites where they might have been experiencing oligo progression with radiation, and then they continued back on immunotherapy. So that was one sort of subset of patients. There was also a subset of patients that developed pseudo-progression as well, which is this concept of, your disease almost looks a little bit worse initially on immunotherapy, but if you wait a little bit longer, it actually tends to look better. They're deriving a response, it's pseudo-progression, it's fake progression, and then they kind of get better. And so there was a subset of those patients. And so, we still have some further studies going on to kind of better identify which patient population within the older adult population could benefit from a treatment strategy like this. But it was nice to see that there is this potential subset of patients that can derive clinical benefit.
Thank you so much, Dr. Singhi. That's really interesting. So basically, you answered a couple of my questions that I was going to ask anyway. But I wanted to know, how does radiotherapy kind of, go in conjunction with immunotherapy, especially in older patients with non-small cell lung cancer who have comorbidities? Like, do you see this landscape evolving in the coming future?
Yeah, there's actually a lot of nice studies that are currently, enrolling and pending sort of readout. So we have an investigator-initiated trial here called the Lone Star trial, which is a trial that's looking at giving patients upfront immunotherapy. In this case, it's actually dual immunotherapy with Nivo and Ipi. They get therapy for a particular amount of time, and then the patients are randomized, if they're deriving a clinical response, to obtain local consolidative therapy, either with radiation or surgery, or continuing on the immunotherapy, the dual immunotherapy itself. And so we're looking to see, is there an added benefit with regards to progression-free survival, overall survival, by adding in using multimodality therapy, even in stage 4 advanced metastatic disease? That really is breaking the dogma, if you will, where we've been so focused in the past that for stage 4 disease, you only get systemic therapy, but we're learning that there are opportunities to better personalize, to potentially include multimodality therapy to derive improved treatment options and sort of benefit for patients. And so that's an active study. I look forward to really seeing the results. We also have some studies just like that using local consolidative therapy for targeted therapy patients, patients that have an oncogenic driver mutation. So like an ALK mutation or an EGFR mutation, for example, getting upfront systemic therapy in the stage 4 setting, having a response, and then seeing if local consolidative therapies can allow the patients to remain even longer on their targeted therapy and to have a better outcome.
Thank you so much, Dr. Singhi. I actually really love the idea of personalized medicine being a potential threat to already set treatment guidelines. So that's really great to hear. So my next question is, what is the research that you're currently working on? Like, what do you think has a real potential for revolutionizing the future? What do you think, what makes you tick at the moment?
Yeah, I'm going to leap off of what you said about personalized medicine. And so, a lot of the studies that people are doing in the field right now are very focused on personalizing medicine, particular to the disease characteristics, to the biology, to the oncogenic driver. But sometimes we forget about what's actually embedded in the word personalized, and that's the person, right? And so what is the person's experience? How can we better, define their cancer journey experience and their treatment experience? And so what I just presented at World Lung on behalf of my group, Dr. Akash Desai, Dr. Fawzi Abu-Rus, and then Jill Feldman, was research looking at assessing the availability and demand for patient-friendly resources, specifically in lung cancer care, and focusing on the patient perspective. And so what we did was we prospectively surveyed patients that had a diagnosis with non-small cell lung cancer to better understand what's currently available, what's out there with regards to easy to understand resources in lung cancer care, and then what are patients looking for. And so we received several patient responses. I will say with the caveat that the majority of these patients had stage 4 disease. They were female. They were from North America. So a very focal subgroup of patients with non-small cell lung cancer. And what we found was that at the time of diagnosis, 95% of patients, I believe, and 2/3 of their caregivers and family members had already sought out information about their disease and treatments online. That's at the first moment that they learned about their diagnosis. And close to 40% of those patients said that the information they found was very difficult or difficult to understand. And so despite actively trying to seek out information about their treatment, patients and their loved ones are finding information, but they just really don't understand it. And so how can we better distill that down and meet patients where they are? So we conducted some questions within that survey to ask about, one, is there enough information about particularly the diagnosis that they have? And over 3/4 of those patients reported that their oncology provider did not provide them with any patient-friendly resources about their disease and their diagnosis, when over 90% of them would have wanted to get some type of information that was patient-friendly directly from their doctor. So that's just one key statistic that we learned from that experience. And so ultimately, what we took away from that was that patients are actively searching online, actively trying to get information about their disease, about their treatment plan, about potential side effects related to therapy, and they want that information from their provider directly. And so I think, this is almost a calling to us as providers specifically, that we really do need to engage, be physician champions, conduct active research to meet patients where they are, because there's a demand for it. One of the ways we're trying to bridge the gap with that is by creating patient-friendly plain language summaries of key clinical trials, so then patients can better understand, what is the data behind a treatment plan that's recommended for them. And so we actually did create a little pilot plain language summary about the ADAURA trial, which was a trial evaluating adjuvant osimertinib in resected EGFR mutant non-small cell lung cancer, and got overwhelmingly positive feedback from the patients that we surveyed. And so thinking ahead, I'm actively writing up a protocol now to prospectively study patient education in clinic. One, to see if it can be implemented into clinic successfully into the workflow. That's a very busy workflow at times, for sure. And then second, to better understand and identify benefits for patients, and then identify benefits for the providers, because I think the only way we're going to really be able to advance patient education in clinic is, one, can we do it successfully and integrate into the workflow? And then second, make sure everyone's benefiting: patients, the oncologists, the oncology team. And so I'm looking forward to kind of being a pioneer in that area and working with a few different groups here to get that done.
Thank you so much, Dr. Singhi. I really appreciate the effort you and your colleagues are taking in personalized medicine to kind of, combat these challenges before they become more challenging. So that's really great to hear. So I guess my last question would be, thank you again for the opportunity we got to learn from you today and your important work. So my question is, what do you hope to achieve in your career in the future, and what do you want to be remembered for?
Oh, wow. That's a great question to end on. I want to be remembered for the care that I give my patients. I take a lot of time and pride in the care that I provide for my patients. I think that's the first and foremost thing for me is making sure my patients feel valued, that they understand what's going on throughout the various phases throughout their cancer treatment journey, and that they appreciate the fact that I'm not just trying to treat the cancer, but I'm trying to treat the person that has cancer. So I think that would be my priority, my focus. I'm hoping to make an impact on the field of patient education, particular to lung cancer care. I'm very interested in developing projects related to patient-reported outcomes so we can learn directly from patients and improve clinical outcomes, improve treatment tolerance. And then I spend a lot of time as well interacting on social media and trying to, enhance and develop education, not only for patients, but also for my peers and for myself. And so, making an impact in the medical education sector is also very important to me. So I'm hoping that I'll be remembered for that as well.
Thank you so much, Dr. Singhi, for that wonderful answer.
Thank you so much. We've just been honored to hear about you and your story and all your past and your present accomplishments. And I know there'll just be many more in the future. And learning about you and your important work. How can our audience connect with you?
Yeah, please. You're welcome to email me. You're welcome to connect with me through Twitter, or X as we call it now. If you can provide them with my handle, it's eSinghi MD. I'm happy to connect with anyone and have a particular focus in helping mentees, trainees, people that are also very actively engaged in medical education or in patient education. And so I'm happy to connect with anyone. Yeah. Of
Thank you very much, Dr. Singhi, for your time today.
Of course. Thank you for having me. Thank you for the incredible work your organization is doing.